You said this side, no? He said this side. माझ्या फोनने पण क्लिक करत राहा चार्ज झाल्यावर माझ्या फोनने. Yes. A very good morning to one and all. At the outset, I thank all the registered delegates and all those people who have presented their wonderful comments on the Facebook and on the YouTube channel yesterday. We thank all of you and for recognition of our efforts that we made. Today's case we will start in a few minutes. I will give you a gist of the case history initially, then we will proceed towards the case. So this is a 48 years old patient residing in Mumbai. He has a history of trauma 39 years back, followed by trauma. Approximately 10 years later, patient was asymptomatic. After 10 years of the trauma, that is almost 28 years back, he suffered severe pain in the tooth, in upper front tooth. He went to a dentist, underwent a root canal. The root canal went very well for the past 26 years, then it ultimately failed. 2 years back, he started getting pain and swelling in this tooth. Is the patient? No systemic disease, physical and medical condition is appropriate, non-contributory to the surgery. This is the tooth that had received the trauma. Intraoral examination reveals fractures which has to be subsequently restored, discolorations which need to be managed. Post-endodontic restorations can be seen. Intraoral periapical radiograph indicates involvement of both the teeth, a large periapical radiolucency along with a foreign body material inside the radiolucency. This treatment was carried out 2 years back. Since then, patient has been having dull ache and sometimes gets an exacerbation into an acute condition, which usually resolves after medication, but these symptoms are consistent in the form of pain on digital pressure in the area as well as dull ache. OPG indicates a large apical radiolucency with the foreign body extruding out of the canal. CBCT indicates the lesion. Buccal perforation can be seen. No perforation seen in this section. You can see the involvement of the teeth and amount of lesion here. Three-dimensionally, the lesion lies more over superiorly and distally in the lesion in relation to the lateral incisor in the second quadrant. These are the measurements and the picture. Bleeding time, clotting time, PT-INR, everything is in place. All the routine investigations for surgical, pre-surgical preparation has been done. TSH, T3, T4, PT-INR values, everything appears to be in place except that patient had low levels of vitamin B12, which we are managing for the last 1 month with injections. Provisional diagnosis, infected periradicular cyst along with a foreign body. So stay with us, we will be soon starting the procedure. Thank you so much. कौन है? काम शुरू करो यार, आज एकदम इजी है. ओके, थैंक यू. वन डायप्टर सेटिंग. डायोप्टर मार्क्स. ओपन. चलिए, डायप्टर सेटिंग्स आर 1-1, नो? हाँ, +1. Good morning, everyone. Thank you for joining us. Soon I'm starting this procedure. At the outset, you are seeing the patient's face on the screen right now. You can see that in extraoral examination, there is no loss of symmetry or no extraoral swelling. Patient has refused to shave the mustache because of the cultural and emotional attachment. So we had to accept it. We have done the extraoral scrub and intraoral scrub already. Now we will begin with the administration of local anesthesia. Gel. We are working in the second quadrant. Lock the casters of the microscope, please. Applying gel. We have ensured that all his blood work is clean. आपने सुबह में नाश्ता करके आए ना, जैसे बताया था आपको जी. वो खोलेंगे सर. As we discussed yesterday, deposition of ample amount of anesthesia is important. I have taken an approach to the infraorbital nerve block through the incisor. बीजव incisor angle चालू केलंय का? ऑडिओ हे चालू झालंय. We need profound anesthesia on the second quadrant of the maxilla. Right side we need to involve for the purpose of taking the flap. So we are not planning for a nerve block but for a local infiltration. Beauty of the microscope is you actually see the vasculature due to the transparency of the mucosa. My videos may not show it because of resolution, but it's a beautiful thing to see it. All the tissues, you can actually see the entire capillary networks and arterial network running inside. Totally we have gone, how much cc we have gone? 7 cc. It will be enough. We now go anesthetize. करेंगे सर nasopalatine area. यहाँ थोड़ा सा दुखेगा आपको सर. हाँ, this is usually painful. I'm inside the canal. The specific angle at which the canal opens. So we prefer to go inside the root canal, inside the canal and deposit the solution. Pylorel injections are usually painful for the patient because of the tightness of the mucosal tissue or submucosal tissue. थोड़ा सा मुंह खोलेंगे सर. As an adjunct, giving little bit of palatal infiltration. सर मुंह खोलिए सर. थोड़ा नीचे देखें आप. थोड़ा और नीचे देखें आप. बस. हाँ करेंगे सर. Going inside from the canine, reaching up to the tissues and depositing on withdrawal. This ensures better tissue separation during the procedure. Remaining area. संभाल के बेटा, संभाल के, हाँ. Always advantageous to give gentle massage to the tissues. This helps us to get the deposited anesthetic solution dissipated into the tissues. Ensures better anesthesia because of availability of the drug at the site wherever nerve endings and the path of the nerve is. Ensures better hemostasis. Ensures better tissue separation during dissection. We have just anesthetized, so we will wait for a while, applying gentle pressure in a massaging manner to ensure that the anesthesia gets dissipated well, spreads well, and in the tissue layers. Considering planning of it, as I have shown in the CBCTs, the lesion is involving central incisor and the lateral incisor. It is reached up to the canine. So we want to raise a flap distal to the canine. But if you see that there is too much of a prominence of the bone here, you might considering taking a flap here. The tissue is mobile, so it's fine. We can take it distal to the canine as well. Okay, as the lesion does not lie distal to the canine. Involving central, we go mesial to the lateral. If you keep it cut to cut here, you fear tearing of this flap because attachment of the frenum here is very taut, very tough. Sometimes during raising the flap, you tend to tear it. So always better involve, and second, this tooth is involved completely. All your incisions had to be placed or has to be placed above the sound bone. So we will take an incision here, distal to 1 here, or mesial to 2 would be better. So it's my habit to usually mark it and plan it on the patient. So to begin with, the procedure, तुम्ही फोट घेत राहा सारी गोष्टी. थोड़ा सा नीचे देखिए सर, हाँ ऐसे ही देखिए बस. वेरी गुड, थैंक यू. आपको कोई तकलीफ नहीं होने देंगे, आप आराम से रहें सर. और आपको पूरा मालूम पड़ेगा जो कुछ चल रहा है, लेकिन आपको कहीं दर्द नहीं होगा. Mesial to the lateral, take the blade deeper, rest on the bone and separate the interdental like this, and then go into the crevice, gingival crevice, and walk the blade on the contour of the bone, touching the tooth everywhere. Microscope shows intricate details of what's happening there. If you commit a mistake, fraction of a millimeter, the microscope shows you. What you see on the video is very, very less. थोड़ा सा मुख खोलेंगे सर आप जी ऐसे. There is an inflammatory tissue lying beneath this line of incision, so that is indicated by profuse amount of bleeding I am getting here. You must have seen that in the other quadrant on the contralateral tooth when I took the incision there was barely any bleeding. Distal to 2 also there is barely any bleeding. However, you could see that there was a lot of oozing when I went here. distal to canine. I'm supposed to make an incision here, a releasing one. Once you cross the mucogingival junction, avoid cutting the deeper tissues and the muscles. They are important. Here taking the releasing or vertical incision in relation to the lateral incisor. It's oozing right now. We'll wait for the oozing to reduce a little bit and apply pressure at the site of an injection of anesthesia. बंद करेंगे सर थोड़ा सा. हाँ, अब खोल देंगे, मुंह खोल देंगे सर. हाँ बस. Raising the papillary part of it. Everybody has a style of working, so this is the way I have been working. There has been a small tear at the root prominence of the canine. You can see that, but that much will easily be accommodated and it should heal. Should not hinder our procedure or the healing process. Very, very minor. So obvious because we are looking at it in the microscope. Suction, please. There is a lesion here, so unable to raise it because it is adhered. I'm applying quite some force here, but not able to raise it. Yes, see this. This is the attachment, which is inflammatory attachment. Very taut. This must be a sinus tract in the past. Oh, this is a tissue which has grown in continuity inside the infected cystic lesion. That's why it's not separating. See, this is the papilla. This is the base of the papilla. Here is the mucosa. This is the mucogingival junction. The inflammatory tissue has perforated the cortex. Suction it here to show why it is not getting raised. The flap. Why it is so adherent? See this continuity. You see that the lining of the cystic, the granulation tissue is in continuation adherence with, because it has already destroyed the periosteum and continued. So no matter how much I apply force, I won't be able to do it because it's a very tough tissue, and there is only periosteum there, and periosteum is a very tough structure. So what I need to do, I need to separate it. I separate it, and see, granulation tissues are very, very vascular. So the moment you touch or teach them, they will start oozing out. Everybody sees on the screen, it is oozing out a lot. Okay, so now I go proceed. Now you see, it should be a cakewalk raising this flap. See, I was applying so much of physical force, not understanding why I was getting it. See now, single stroke, I could raise the flap. Okay, surgery is a patient job, very patient. You see the lesion now. You almost have a visual on the lesion. See, I need to separate this attachment, mostly caninus muscle, I guess. Yeah, this is a papyraceous bone. You must have heard the word eggshell crackling. Very common question in exams and vivas, eggshell crackling. This is the bone that gives you eggshell crackling, as if you are moving a piece of paper. Once you palpate, this gives you eggshell crackling. See, with simple mosquito, it is shredding out the bone. I need to shred out these bone pieces. बोलो बेटा. Huh? No, I won't destroy it. See, what I'm noticing here is that lateral incisor has lost a lot of bone support. Not very evident on the CBCTs, or not very evident on the IOPs also. But if you can see, the bone, it is lost a lot of support. This all is granulation tissue, which subsequently will be removed. Okay, we will not go behind the lesion. We have raised the flap on the second quadrant. Now we concentrate on the first quadrant for raising the flap. बेटा ये retraction में nostril block नहीं होना चाहिए patient का. So in periapical surgery, especially in the maxillary anterior region, always remember to retract in such a manner that one of the nostril is left very much patent for the patient to breathe normally. Okay, if there is a compromise in the airway, it will ultimately cause a lot of anxiety to the patient, the breathlessness. Okay, subsequently you may get a lot of events. So be very careful whenever you are performing it yourself. Be very careful to retract, because our focus is primarily retraction. We desperately need to have a clear light input into the surgical site, clear visual access to all the sites, and a clear operative access to all the corners of the lesion. However, breathing remains of paramount importance. Never allow the tissues to get dried. Even the hard tissues of the tooth, I keep on mopping it with the saline solution, so that the hard tissues and the soft tissues are continuously being hydrated. Suction. राजेंद्र सर, तुम्हाला ते सांगितलं होतं ना, काम करून टाक. But what is this? See the CBCT once again. I have encountered a bony cavity here, distal to 1. Does not normally indicate a healthy. Incidentally, we have raised. I'll just see whether it's a natural fossa in the bone or something out of the usual. But just see the CBCT once again to verify that this fossa is natural anatomical feature. Distal to the root prominence of the central incisor. Distal to the root prominence of 1-1. It has to be normal anatomy. There doesn't seem to be any specific pathology there. It's too obvious and prominent, so I wanted to re-verify it on the CBCT. Beta, check karo. Separating. This is all adherent granulation tissue that we will have to do a sharp dissection later. See, this is a sinus tract part healing, healed sinus tract, parolis, what we call it as. But right now, after raising the entire flap, our objective is to reach out to the heart tissue there and finding out the confines and the boundaries of the infected cystic lesion. This is the discharge. Can we get a stronger suction if we change it to a disposable tip? May I have the सर्जिकल बर? नीचे देखिए थोड़ा सा सर, आप बस थोड़ा सा ज़्यादा है, बंद करेंगे. Great. Take the coolant. Ready with the coolant. No, put it off, put it off, put it off. Reverse the direction of motion. Correct direction of motion now. It was anti-clockwise earlier, has to be clockwise. Removing the thinned out bone, preserving buccal cortex, whatever the lateral is left with a meager blood supply, whatever it can have. If I find that the bony edge is too sharp, we'll have to remove it. Saline. Replenish the saline, please. This is either post discharge and discharge of that foreign body material, which is mostly calcium hydroxide. We have suctioned it out. Hold it, beta. This is the foreign body material that's coming out. You can see fragments of the material coming out. I may have some gauze to remove that material, please. Suction, can it go inside the lesion, beta? Go inside, because it's in yesterday's case we got the whole chunk out. This case it is difficult to get the whole chunk out. You can see the cystic lining here clearly outlined. Yes, this is the whole cyst. This whole ball is the cyst lining, okay, and this sludge which is coming out, this slurry is coming out, which is diffused calcium hydroxide. This we avoided in yesterday's case, and we dissected it out and removed it in large chunks. But this case it is already diffused. Suction up. Okay, to dissect it from the palatal aspect of the lateral incisor, I would like to make the root of the lateral incisor even before I do it. So need to achieve hemostasis for a while. Okay, we'll wait for a while and then peacefully suction it out, beta. Control the hemorrhage for a while. Now, why am I doing this? I am doing this because we want to amputate the root apex of the incisor. Why? Because I want to take a good access to the parietal aspect. It is most adherent in the parietal aspect. I think this is just a bone cavity. This is a natural bone cavity. If you take an IOPA, you will see it as a large lesion. I have verified on the CBCT, it looks like a lesion, but appears so far it's a natural cavity. It's having muscle attachment, so we are not touching it at all. Now see, we have isolated this tooth from the rest of the lesion. I will go do the apical root resection. I will go and do the apical root resection. May I have the coolant in the burr tip, please? Thank you so much. Dr. Ishma, Dr. Shaili, helping me a lot here. Thank you. Dr. Shamal also. Dr. Prachi and Wendy here. Get me the CBCT image on the screen, please. Need to see the contour of the bone here. Interoperative referral to the diagnostic images is of very much importance, because it looks one thing in the mouth, it looks another thing on the IOPA, it looks like a third thing in the CBCT, and when you open up the tissues surgically and start exploring the anatomy, that is when you see the truth. But once you see it, before believing your eyes, go cross verify it again from the CBCT. This is the entire cystic lining, if you can see. I am not hurrying it up to remove it. Okay, see, this is, yeah, I think this is the Kodak moment for us. This is the main chunk of the lesion coming out, the foreign body. Yeah, this is the foreign body. After separation, now I am curating it out. See, I can't apply, it is truly adherent, very, very firmly adherent to the parietal side. This is the bulk of the foreign body material coming out. Yesterday I received very motivating comments from a lot of people and a lot of good criticism also. Very happy to read all of them. And what I realized is everybody's perspective is different of the same thing. When we do endodontic surgery, and by being from the endodontic and conservative fraternity, my primary focus and objective, spoon excavator, primary focus and objective is to salvage the roots. I do surgeries, yes, for removal of the pathology, but that's not only thing that I aim at. I primarily aim at saving the teeth if possible. So when we perform endodontic surgeries, we are very patient and we are having minimal access. We try to do things through minimum destruction of the bone in first place, and then root is our main focus. So in endodontics, these surgeries have, from periapical surgeries, these surgeries have been now named as periradicular surgeries. So it is working around the root. So if you can see, if I want to take out this lesion as a whole and be happy about it, I can directly go in and cut this root and remove the lesion in toto, but I don't want to do that. I could separate it. See, this is the distal extension of the lesion to the canine. This is superior towards the nose. This is the mesial towards the intermaxillary suture. I have separated it all, but however I don't want to hurry it up because I want to peacefully dissect it from the palatal aspect. Yeah, just use the suction beta. So the attachment inside. This suction could have been slightly more stronger. The lesion is on its way out in toto. As I told you, this is a very fine area there, which I want to work with a. Kelly madam was getting a spoon excavator. It is there in the autoclave set. These are surgical screw. The one that we use for caries. Thank you. This is a spoon excavator. Yeah, this is one of the best instruments here to detach and to scrape out. See, this is the lining that is coming out now. Without destroying the roots, without destroying much of the bone, I've been able to dissect it. Yes, now only area it is attached is here. Here I go. Ask him, is he comfortable? हाँ, आराम से सर, हाँ, कुछ आपको तकलीफ नहीं होने देंगे. काम हो रहा है आपका, आराम से हो रहा है. जो अंदर गांठ थी वो ऑलमोस्ट निकल गई है. 5-10 मिनट में तो पूरी निकल जाएगी सर. I'm dissecting out. मुंह खोलेंगे सर. Parietal cortex is not perforated. Suction beta. Do we need the compressor? Please put it off. We have systematically the lesion we have taken out. You need a solution for the biopsy. May I get the, which solution is this? Ask oral path people. The lung is not favorable. Get it coordinated from the pathology. Solution to carry it. Shamble tighten it. Gloved, no? Yeah. Slightly, yes. Not very tightly. Good. Fair enough. थोड़ा नीचे देखिए सर. May I have the coolant, please? Oh. Be careful. Yes. थोड़ा नीचे देखिए सर. हाँ बस. If you can see the GP of the central incisor, you can see the GP of the central incisor. Curating that area. After curating, we are removing the excess GPs there, and we are working on the root of the central incisor here. Coolant, please. Irrigate, please. Irrigate, please. There is a lot of debris because of the removal of the gutta percha from the root apex of the central as well as from the lateral and as well as the foreign body. There was a lot of materials lying everywhere. Hold it. Lot of GP, lot of calcium hydroxide, lot of sealer, everything in the cavity, but all for good. We have removed it. Cavity looks good. Free of little bit of fragments here and there are remaining. I'm trying to remove them. So this is some more foreign body material coming out. Just see where it has gone. Yeah, it is this material again. Suctioned it out. Dr. Reshma helping me here with the surgery is a maxillofacial surgeon. This is excessive tissue. And this is a sharp bone. The sharp bone cannot be left in the lesion like that. So we have to get it smoothened off. Now we are seeing bare bone, which is almost healthy bone, like almost everywhere. So you see that very healthy yellowish bone is seen, whitish yellowish bone. This is absolutely clean cavity. Okay, inside we still have some bleeders there. So let them bleed. It's a healthy sign, no problem at all. If you see, there is no lining left anywhere. थोड़ा नीचे देखेंगे सर आप. हाँ, इस तरह से ना it's gone out of sight. हाँ, you see it. Except that I need to work again back. As this is a microscope, it tells you all. It doesn't hide any truth. It is like a mirror. No matter how you want to look, it will show you how the way you actually look. So see this apex of the one. In the CBCT there was nothing there, but if you see, there is GP here and there is some extruded material from the one as well. Okay, we are removing it now. I've been doing surgeries under microscope since 2004, so you develop an eye for seeing the line of the PDL and locating the color differences. See, this is the bony area, this is the root, this is where the root takes a turn. Apex is here. Apex, I think the master cone used was black in color, so I can see clearly a black GP there. Usually using pink GPs, no? So here from the apex I can see a black GP. I think so. I hope that the video is showing it. Usually color balance and the visibility that you get in the microscope, what you see in the videos is not even 10% of the clarity what you actually witness under the microscope. It's a different world altogether when you work under a scope. Yeah, see, my root resection has not been very proper. You can see that I have made the ditch mark. So I need to go there and smoothen it off. And this is the granulation at the apex of the central incisor. 25-50 घेतले का? घे चांगले. As I said, I need the coolant at the tip of the burr. Yes. Now getting a uniform preparation of the root apex. It has a ample buccal bone support, and the portal of exit of the pulp lies very much palatal. Okay, see where my burr flutes are ending towards the shaft, there is the orifice. This is the orifice. Yeah, thank you, Shelly madam. Now I am working on the palatal aspect of the root of the one. See this tissue. This is a granulation tissue. If I don't remove it surgically now, there are chances that it may grow more and ultimately cause a newer lesion in this area. So once you are in and you get a lesion, remove it. नीचे देखेंगे सर थोड़ा सा, हाँ बस थोड़ा ज़्यादा नहीं हिले सर, हाँ बस 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 बस. Good enough. We have had good access to video नहीं लेना. Next step is to pack the lesion. Normally ferrocrelum solution may be used, but this case is not bleeding that much, so I am packing the lesion with a gauze having saline and betad in. We'll achieve some hemostasis in this area. After we achieve the hemostasis, we will start working on the root apices. Okay, we will inspect the root apices under a higher magnification. We will see if the beveling is correct. Earlier concept was to resect the root, 45-degree angulation of the long axis of the root. Now we go absolutely 90-degree. Close. We are giving the patient a break here. Somebody has posted a question here asking about how I have given the block from the central incisor. We have given anterior superior alveolar nerve block, that is also called as infraorbital nerve block. So in this case, we have gone through the access taken was from mesio-incisal line angle to the disto-cervical angle. So diagonally dissecting or bisecting the central incisor, then we went to the anterior maxilla and reached the vicinity of infraorbital foramen. There we deposited the solution. Now why it was done? Many of the people will take an alternate route through the 2-5 or second maxillary premolar and go straight upwards towards the infraorbital foramen. In this case, I opted for that route because after I deposit the solution, ultimately both approaches, the second premolar or the central incisor, both approaches will reach the infraorbital foramen. However, here I took the incisal approach because it gave me one more opportunity to deposit the solution on withdrawal. You must have seen that the anterior maxillary lesion lies in the path of the needle. So that saved me at least 2 more pricks in the same area. So one prick, I deposited the desired amount of solution in the infraorbital nerve block. On withdrawal, I gently and slowly withdrew and deposited solution on withdrawal into the tissues to achieve profound anesthesia, and into that highly vascularized granulation tissue, I could get better hemostasis. Now we have given it almost 2-3 minutes for the oozing to stop. Why are we waiting here? We were lucky to find entire foreign body out. We were lucky to take out the entire lesion in one go, not piecemeal. If it is piecemeal removal, histopathological examination becomes a challenge because they'll send a report that insufficient sample or non-specific inflammatory cells or something like that comes out. So it is always better not to compromise the bone integrity, not to compromise the integrity of the tooth structure, not to compromise endodontic prognosis or surgical prognosis. Objective should not be to take out the lesion in toto. Objective should be to salvage the bone, salvage the root, and protect the healing ecosystem there. Okay. So I hope I answered the question of the choice of anesthesia. Pair of glove. टिप लगाया. Suction here. See this clean cavity with no tissue fragments and the root apices. Still we have a bleeder here. Now I will show you the apex in a mirror. Beta. Can you see the apex in the mirror? Yeah, it's nicely condensed. Take a picture here. Focus. Tell him to take a DSLR here, close up of the root apex. This space might go for publication, so I need it. This is the root apex of the central incisor, sorry, lateral incisor, and the central is here. I'll post it. Pose it. There is posing in that area. Yes. Suction, please. Yeah, it is rather seen better with the direct vision. I'll show it in the direct vision. I can see it very comfortably. Video may not show it. See, there is a black color spot here, a very small spot. See, I can have a clear visual axis. This is the spot. You can see the blackish discoloration. Change the angle of the microscope. Loosen the knob, please. Direct vision will show it better. Loosen the vertical also. बेटा इसको yes achieved, done it. Okay, I'll start my procedure. Thank you. सर जी आप कंफर्टेबल है ना? जी आप आराम से रहें, कोई तकलीफ हो आप बताएं, आपको ज़रा सा भी पेन नहीं होगा. जो अंदर गांठ थी हमने बताया था आपको, और एक कोई बाहर की चीज़ थी, तो दोनों चीज़ें निकल गई हैं. हम लोग दांत के ऊपर काम करने वाले हैं, बारीकी वाला काम है, आराम से करेंगे इसको. ये है पता नहीं. You have another tip? सर ठीक है. As we have already cleaned the entire cavity, before doing the retrograde preparation, because retrograde preparation is going to take out some amount of debris, I would like to pack the wound. with a gauze so that it receives the debris which come out during the procedure. You see that microscopic tip to prepare. Yes. Yeah. This is a GP coming out. You see, I have prepared it to 2.5 mm. That is sufficient here. Beta, water supply, scalar water supply. Decrease. Too much of water supply here. Can you decrease? Can you decrease? Decrease. I prepared the root apex with the tip here. Focusing at higher magnification and showing the students once again. See, this is the tip that goes in and prepares the root. Clean cavity. It is thermoplasticizing. These are the GPs. They have to come out from the apex of the tooth. May I have the irrigant here? Madam, please suction it out. Excess debris being removed. Remaining GP can be compacted using a micro instrument. I have it. The microscopic instrument that I am using nowadays are available in the market. All these belong to the time where it was not available anywhere in the world rather. This is Mumbai made in a workshop and I am using it for years together. This is the routine preparation I have done. Removing it carefully along with the debris. A small shred of tissue you can see hanging around the apex, and I am removing it like this, the tag. Now you all will see the difficult part of it. This is a true microscopic approach. If you can see, see, this is the debris I need to remove out. Still there was a spillage. See that after so much of precaution also there is a spillage. I hope the microscope is showing it. Yes. Suction out from the other end. Yes, thank you, madam. I will give it a gush. Yeah, some of it has got impregnated into the bony irregularities. The calcium hydroxide. That's our enemy here. It causes chemical burns, you know. Yesterday's case also was similar. That's why we planned this case series. Once upon a time, an era of endodontic procedures was called as calcium hydroxide mania. But anything and everything, people were putting calcium hydroxide everywhere. This is a different type of calcium hydroxide mania which has come out now. You can see me angulating it properly. Yesterday I described, wrong button pressed. Control the oozing. This is very bad for us. Still the tissue are oozing out. As I told you, endodontic procedure, microsurgical endodontic procedure at the apex is very, very, very sensitive. Isolation, very important. More important than your hard tissue treatments, because here your MTA will completely flow out. So disaster and a failure. Why it is not working? It's working now. थोड़ा नीचे देखेंगे सर, थोड़ा इतना ही लेंगे. Suction out. Haley, click this image. Look it. Look it. Okay, we are done with both the cavities here. I need to come back diluted with irrigation. May I request someone to please dispense me the retrograde filling material, bioceramic material. I'll hold the suction. You can please do the nice. Oh, we have debris palatally. See this? Yeah, small fragment. Small fragment palatally. I need to remove. Wait, beta. Wait. Hold this. Yeah. Good enough. Now I'll pose both the cavities made at the apex for a picture after controlling the moisture. A picture means for a mental picture for the viewers, the students learning from this surgery. Okay. Beta, where is the micro mirror? I just now called it a micro mirror, which is, this is, I'm lying, this is an ENT mirror. I request you all not to buy micro mirrors, because they are the same ENT mirrors sold in the name of micro mirrors, and when they call it micro mirrors, the cost escalates 20 times. This is a prepared cavity. Can you all see that? 3 millimeter. No. Are you? No, you are not in focus, beta. It's good. Yeah, this is the retrograde preparation. It has come out beautiful. I'm praising my own self here, but I like it. Suction. I like it means I like the root and preparation. It has come out nice. Though elliptical, it has come out beautiful. There has been no excessive inadvertent tooth removal, because you're blind when you go at the apex with a microsurgical tip, you know. So you sometimes end to destroy it a lot. This cavity is very difficult to approach for the photo. Now you can see it. You can see it on the photo. Yeah, you can see that. Smaller mirror we have, yes. And it should show now. But it's okay. We don't get a photo. We are working not for the photo, for the patient here. It comes well and good for a publication and record. It's important that no, it's a natural bleeder. It's not an inflammatory tissue. Coming for the PDL. Gel foam we have, but our purpose is solved beta already. There is that we need. Chalo. Yes. नीचे देखिए भाई साहब थोड़ा सा. You can now see the through small channel. Can you click that? Do it. Achha, it's wait. Yeah, that black hole is small hole. Yes, dark where there is no light. Yes. No. Yes. Now this is good. Okay, fine. So now we will again make a small bed of ते करतो ना ते apex बघणं सोपं नाही रे. If you have to see the apex now, it has to. Yeah. No, I'll do it with a direct vision now. I wanted to inspect the apical cavity. I did not do it for the photograph purpose. I needed to inspect the cavity because we are not used to making a cavity in the apex on daily basis. But I'll do that. Give me a moment here. As learners, the students are not used to making these cavities, so angle can go wrong. If your angle goes wrong, you tend to destroy the root a lot and getting a weird angle for the work. See, now this is the angle which I need to pack the MTA in this tooth. Making a bed for, because excess MTA I can remove. I don't want to sprinkle the MTA everywhere like a fairy tale. So give me mix please, Dr. Shaili. MTA mix please. This is the root apex. थोड़ा नीचे देखिए सर, बस. Little bit of MTA. Where is it? Very nice. Very huge quantity here. Picture. You see that placing MTA has gone inside. Give me that ball burnish, a small ball burnish. I have designed it. Yes, the egg shape. The other is the end egg. Yes, other is the egg end. Yes, this is an ball burnisher for compaction of the MTA. Rajendra, Shaili, you saw that I kept the MTA only in a specific position and now I am doing the compaction, retrograde compaction. This is retrograde compaction. Conservative and endodontic work has to be clean without spreading it all over the place. Need to do good job. See that? How the apex is being managed? Very peacefully and then slowly, slowly. Yes. And what should you do now is patient waiting for initial set of the MTA. Do not hurry. Whenever we do a surgery, we have some kind of a hurry here. We should not. Endodontic surgery is peaceful work. Okay, never be in a hurry. Wait for the initial set. Considerable bone loss with the lateral incisor. For a man of 48, it will be difficult to regenerate so much of bone. See, entire buccal thing lost except this 2-3 mm bone here. Entire palatal thing lost, and this mesial and distal support. That's it. That too around 4 mm each, 3 to 4 mm each. So it's quite compromised a clinical situation for the lateral. But only positive thing here is no mobility. And this clot will organize into a nice bone around maybe 6 months to a year's time. It will be a reasonable bone and complete the complete deposition approximately in 2 years time, maybe faster if he is healthy. Currently we have evaluated his thyroids and vitamin D. They are on the sufficient side, so we don't see any downside to the healing. Okay, I may remove it now very peacefully, not to dislodge my own MTA, which I took so many efforts to place. One wrong movement can dislodge your MTA. Okay, MTA is not amalgam or composite that has been cured inside a cavity. It can come out, it doesn't bond to the tooth structure. You see the movement, you see the action with which Shaili ma'am, just take it here. Take it here. Yeah, very nice, Shalima. Take it again. Now going towards the central incisor. May I get some gel foam here? Yesterday somebody posted me a question on my personal chat about what solutions are better to be used for hemostasis. Yesterday what we did, yesterday's case was used, sir, ठीक है ना आप? Yes, sir. Yesterday what we used was ferroacrylam solution. Okay, application was different. Very large apical lesion involving multiple teeth, huge granulation, rich vascularity, anxious patient. So we had to use that solution overall throughout the lining of the lesion to minimize bleeding process. This case, we have a specific site. If you see the PDL here is bleeding, it's not the granulation tissue. I have verified with the highest magnification. It seems to be having a small arteriole or something like that there, some bleeder. I don't want to unnecessarily drill it with the bone because there doesn't seem to be a granulation as such. So I intend to use a gel foam here. See this area. This is one bone vessel bleeding and there is one vessel here somewhere which is oozing. That is filling up this small catchment area and putting the blood, which is going to destroy my MTA completely. MTA cannot sustain this, okay? So I'm putting gel foam in that area with a use of microscope with a higher magnification, very small. That's the beauty of using magnification. Believe me, even if you don't, then most of the surgeries you can do successfully if you adhere to the basics. Adhering to the basic is most important. Give me a gauze here. Suction please. कहाँ पे रखा है बेटा? कोई दे दे मुझे. हाँ, उसको कट करना पड़ेगा ना. No, not the whole thing. I want a small piece. I'll do it with the. No. Very small, microscopic. Yeah, that is enough. This is gel foam. I'm using a spoon excavator to place a very small piece of, suction it out. It will sit here. You see, it will not allow any further bleeding to happen. I'm in focus. Sorry, I'm repeatedly asking whether I'm in focus or not because today I'm looking into the microscope. And sometimes the power focaling can be a problem. Power focaling means the microscope and the cameras or the viewers or the co-observation tube may not be aligned in a manner that everyone can see it with the same definition. Now we have control on the situation. Suction please. It is not oozing anymore. Very small piece. I told you in that catchment area of the gel foam. Now what I'm doing here, I'm going to clean off the retrograde cavity of the blood it may have. So what I will use the same instrument that I use for retrograde. Yes, I have cleaned it. Yes, now I use little quantity of MTA as desirable. Very small quantity of MTA. I want an apt mix, very apt mix. This is the mix. Shelly, you're there? Now do it. We have placed the MTA in place, and now we are going to compact it. Really? Gel foam can be left in place. We have the lesion out. Now we start the closure. Dr. Reshma Gaikwad will be closing. I will be assisting. बेटा वो खोल उसमें कहीं चश्मा के सब बैग्स One, two, three. Yeah, we are back again on the audio for closure. Few basic things need to be followed here. We have irrigated the cavity, the bone cavity with the material. We have dissected the flap slightly towards the base of the flap because it can cause dehydration of the tissues over the period of time, can cause retraction a little bit, so there can be inappropriate closure. We are taking an anchor suture. This suture taken in between both the central incisors acts as an anchor, because if you keep on suturing on one side, you excessively close on that side, and when you reach the opposite side, you have a gaping. So not to do that, you have to first give an anchor suture where that suture is centered, maximum firmness, so that your flap remains centered and positioned anatomically correct. Yeah. Somebody has posted a question on the YouTube that do we consider grafting this area? This lesion is very small in dimension. first thing. So likely to heal. It involves only one tooth completely and the other tooth partially. So size is smaller. Secondly, this site was irritated with the calcium hydroxide, and we know that calcium hydroxide is not meant to be inside the bone, this huge quantity. So it's a chemical irritant, causes tissue dissolution or a chemical burn. Site is irritated. Secondly, the cyst was infected. So lining bed of the cystic lesion is purulent, having high microbial load. We have already drained significant amount of pus. So that makes it a site not very suitable for grafting. Now what, yesterday's case, we took out the blood of that patient and then we give PRF. In this case, we feel even the PRF may not be required because the procedure has come out well, the closure is coming out well, there has been not much of destruction of the bone or not much of the osteotomy performed. Again, to declare, the patient has refused to shave off the mustache because of cultural and personal reasons. So we had to work with it. We would normally prefer to shave off the face completely. Describe.
So here we are giving horizontal mattress. There is no bone support. Keep the suture tight.
Yeah.
You should hold the tissue tightly.
Horizontal mattress. This is a horizontal mattress suture to achieve a tight closure because there is no bone support to this area. The closure has to be tight. Section, this area. Somebody has posted a question about the ultrasonic speed to be maintained. Depends on the normal range of ultrasonic is good. Depending on the size of the root you are making and the size of the tip you have selected. If suppose I am working on a premolar root apex or a molar root apex, the roots are very thin. So we keep the speed to be low. Sorry, the settings of the ultrasonic is on the lower side. And if suppose we are working on a central incisor like today, the ultrasonic can be the medium. I never have kept high speed. And remember, like your endodontic instruments, these ultrasonic tips can easily break. So if you are purchasing a tip and try to work on it, I would highly recommend, for years together, all my postgraduate students also, I suggest them that they first have a feel of these tips on the extracted teeth where apices are resected, and do preclinical exercise of retrograde preparation to get a hang of it, to get a feel of it. Because this is the, see, what we are used to is working with the straight burrs, straight diamond point, straight files. These are contra-angled in a manner. These are angulated for 3 to 4 axes to reach a specific point. The whole point of use of microscope in a surgery is to make a small window and enter the surgical site. You must have seen that if I would not have had a microscope and I would not have had a micro tip, it was impossible for me to today to prepare the root apex of the central incisor. Lateral incisor, like Gateway of India here, it's a huge cystic lesion related to the lateral incisor, but central incisor here was hardly involved. Only the distal surface was involved. So I could take a small axis, enter there, prepare and come out. And you have seen that MTA does not make, placement of MTA does not mean making a whole crowd of the MTA there, putting a whole gram of MTA there. You have to be very meticulous. Don't spread any extra material anywhere. Okay. We have multiple tips in the department. I may not disclose a brand here, but the department has procured it here. They are ultrasonic tip having zirconium nitride as a material which is used as a matrix on the tip, and small diamond particles which are abrasive. So basic mechanism of cutting is abrasion only along with vibration. Hydrogen peroxide is not indicated anymore. Online है बोल दे, बोल क्या चल रहा है? Hydrogen peroxide is not a solution which is actually permitted to use in these cases, or any other rather. Because of it be having free radicals, we have minimized its usage. So it is not recommended for a mouthwash. It is not recommended for intracanal use also anymore. So we don't use hydrogen peroxide because it can burn the tissue. It does have potential for causing a cancer in case of long-term use naturally, or else rarely if it is inadvertently injected into a tissue, it can cause emphysema because of the effervescence and it liberating the gas. I hope I answered the question. White MTA has been used. Again, I may not, when we publish the article, that time we will disclose the name of the brand. It is a scientific protocol. We being a government institution, we follow a due procedure with all permission and licenses. Then only the materials are procured here. So I'm not sure whether I'm allowed to disclose the names or not here. So definitely when we publish this case, we'll come out with the brand names of everything that has been used, including the local anesthesia also. That's a protocol for scientific publication. Somebody has posted a question, can we do periodontal grafting in this case? I don't feel any periodontal grafting is required anywhere. Yes, one could think of using a biomembrane here, but we are achieving a reasonable closure and the defect primarily is not periodontal. The tooth which is affected the most is the lateral incisor. Marginal 4 mm, almost 4 mm of bone is intact from the palatal, from the buccal, facial, or from the distal as well as from the mesial. So we don't anticipate any invasion of the epithelium inside the cavity. Yes, if one can use it, it may add some value to this case. I really appreciate the suggestion. Thank you so much. Lower lips are getting dry. Wipe it, Pita. Always keep all the tissues in the surgical site and the periphery hydrated. Never allow them to desiccate. You are going great as far as the closure is going. Madam has very diligently used an internal mattress suture. The tight closure is required. Rest of the areas we have here ample bone support. All circular incision areas have been covered by suturing. Now we are closing the releasing incision. Sometimes when the lesion is large and we expect drainage, we do not suture releasing incision. So they act as an escape ways for drainage of excessive exudate that forms. One of the post-operative instructions given to the patient after endodontic surgery is a straw color fluid may come out of your wound 2 days after the surgery. Do not mistake it for blood. Blood, if it comes out of a wound of a surgery, has to be red in color. Straw color fluid is different, and that's the good sign of healing. It's not a sign of worry. A purulent discharge along with the localized pain, excessive swelling, sign of sepsis in the body, increased local temperature, increased redness over the skin, these are the signs and symptoms of infected site which is surgical. If it is discharging straw color fluid after a couple of days, that's a sign of natural and normal healing. These are resorbable sutures being used here. Maxillofacial surgeons prefer to remove the sutures after 1 week's time clinically. We in endodontic surgeries, we prefer to remove the sutures after 48 hours. That we do when the lesions are very small. Larger lesions, we prefer to keep it sometimes in a longer time. And we are blessed that we work in the oral cavity. The blood supply is so excellent, so rich, that if this patient comes to you back after 2 to 3 weeks, you won't even see a scar mark here. That happens because enormous vascularity, amazing blood supply of the oral tissues, rich supply. There was a slight tear of the flap here, which was evident on the microscope. You people could not see it on the video. I was seeing it when I was working. And it is being beautifully handled during during suturing. No dog ear formation anywhere, no gaping anywhere. So far, it's excellent. All seems to be fine. सर जी आप ठीक है ना? हाँ जी. बस टाँके लग रहे हैं. अब टाँके कंप्लीट हो जाएंगे 5-10 मिनट के अंदर. काम पूरा हो जाएगा. Very tight contact, difficult to get a catch for the needle to suture in this area. All of us have been there in this situation. Yeah. In this area, we will be going for a sling suture. This is done when you can't get a catch and you can't pierce a mucosa and get it anchored on the parietal aspect for closure. If you can't take a bite for the needle for suturing, the tissue is too tight and too thin, then you go around a tooth and bring it back from the other end and then suture it buccally. So the suture acquires its anchorage from the clinical crown of the tooth. So that the problem is solved. It is called sling suture. If students want it, please let us know in the comments. We will organize a separate workshop on suturing different techniques. This is the last suture. The surgical wound size, bone drilling, and possibility of drainage is lesser. So we are suturing the releasing incisions. And superior extension of the lesion was quite close to the nose. So we had to take a releasing here, which is crossing the mucogingival and going deep into the sulcus area. Betadine for irrigation, please. Now we are finally rinsing, irrigating the whole area. First with betadine, now following by saline. Long gauze. Pressure. We have taken a gauze moistened with saline, spraying a little bit of betadine on it. like this, and now giving a pack. This will ensure that an antiseptic solution is in contact with the wound when the patient ask the patient to close the lips. Yes, close the lip. Hont pe hont band kar dijiye. Yes. So this closure of the mouth, I'm killing the video feed of the microscope. We are done with the clinical procedure. Let the audio be on. So as you have seen that after achieving a closure, now you must have realized that with every different surgical site, with every interdental tissue, with every type of mucosa, we had to select different type of suture. We started with interrupted suture. One place we gave continuous suture to release the incision. We gave a sling once, internal mattress once. So depending on the site, availability of the tissue, support of the bone, we need to achieve a reasonable amount of closure. Excessively tight closure is bad and gaping is bad. Docker formation is very clear if you have a more tighter suturing. Now what we have done is, we have taken a longer gauze, folded it, saturated it completely with saline, then sprayed some amount of betaine on it and placed it into the labial sulcus. Ask the patient to close. So the muscular force of the patient causes some amount of pressure, a gentle pressure, uniform pressure onto the surgical site. This will prevent any excessive bleeding in that area. If suppose there is excessive bleeding, our flap may swell up and your clot may organize in that fashion. So we do not have that, don't want that disfigurement to happen. So what we have done is given an ample amount of pressure, a reasonable amount of pressure onto it. Now patient will be further instructed to be careful in a city like Mumbai, and most of the patients in our institution travel through trains. So we ask the patient to be very careful during the travel. They should avoid any kind of injury to this place. After 2 to 3 hours, the effect of anesthesia will wean off. Once the anesthesia wears off and the sensations on the lip and the face return to normal, patient might experience some amount of pain. We advise the patient to remove this gauze after 1 hour's time and to drink something, basically water. After 2 hours, they can drink something like a juice, clear thing which will not have any food lodgement in that area. Patient will be advised to be on a liquid diet, preferably for the day-to-day. Tomorrow onwards, patient goes on a semi-solid diet, avoiding very sharp, very hard structures, food items, especially for initial 2 to 3 days. Patient is advised not to keep on spitting. Patient advised if there is a bleeding in the mouth or oozing in the mouth or a fluid coming to the mouth, just to gulp it, not to keep on spitting. Because once they see any tinge of the blood in the mouth, they get anxious that my wound has opened up and I started bleeding again. It may have some streaks of blood. Some amount of blood may leak out of the sutures or the flap. Doesn't matter, the patient glumps it. They keep on spitting it. They keep on taking out the blood by suctioning. The more they suction it out with the pressure in the mouth, the more it causes bleeding. It opens up the bleeders and more bleeding is caused. So tell the patient not to suck out the blood. Some patients develop a habit to play with the sutures with their hands. They keep on pulling them, or they're poking it with something like a toothpick or something. Ask the patient not to play with it. Patient should follow routine oral physiotherapy, routine brushing protocol, rinsing protocol, except the area of surgery that should not be brushed for initial 3 to 4 days. Secondly, and how to clean it? Every time patient eats anything or drinks anything, patient need to rinse. Tomorrow onwards, need to rinse the mouth thoroughly, bringing that disinfectant solution given to them in that area so that no remnant solid or liquid food items remain anywhere, because any food substances that remain into the wound area will subsequently undergo decay, will colonize microorganisms and will infect our wounds. So that should not happen. So patient is advised to thoroughly rinse the mouth and area of surgery post-operatively. As I said earlier, 2 to 3 days later, there is a possibility of discharge of a stroke-color fluid, which usually tastes salty to the patient. That's a natural and normal response. Avoid playing any sport for initial 2 to 3 days. Avoid crowded places where you're likely to hit. Avoid going close to the fire for cooking or any other purpose. That should not cause vasodilatation and increase amount of oozing possibility. In case patient gets any ecchymosis, ecchymosis means discoloration on the skin. Sometimes some concealed or hidden bleeders may start secondary bleed. Right now they are not bleeding because we have been generous with administration of anesthesia and adrenaline in that area. So if the patient starts bleeding after closure, the bleeding does not come out of the wound. It may find some area in the bone and come out subcutaneously on the skin. Nothing to be panicked about. It gets control on its own because of lack of space of bleeding out. The vessel self-strangulates itself, and the amount of blood that gathers below the skin will subsequently be cleared by the body. So no need of a thrombophobe also in most of the cases to remove it automatically. Only thing is that it may look very scary to the patient. Patient may feel that there may be disfigurement or permanent loss of aesthetics. It usually will not happen. Body will clear off in a few weeks' time. Need to strongly reassure the patient. Initially the color would be red. It will be darker red. It will be bluish red. It will be grayish red. Then it will be more blackish and violet color. Then slowly become hazy and patchy and totally disappear. That's the natural possibility. Now, primary bleeding we have explained to the patient. If it bleeds in the night today, patient is asked to keep some pressure from outside and use ice. And how do you use ice? Do not continuously keep the ice on the surface of the wound. The ice should not be kept because it can cause cold burns to the patient. It can cause skin damage. So you have two problems to face now. One is the surgical wound, another is a burn on the skin. So ask the patient to apply the ice not more than 30 to 40 minutes an hour. Intermittent application. You can have application for a prolonged duration of time till the time bleeding stops. However, it can be discrete. It can be with the gaps of 10 minutes each. So give an idea to the patient, recommend them not to use it continuously, but in an hour's time they can use it for 30 to 40 minutes. Now about secondary bleeding. Secondary bleeding is because of infections that may start anywhere around 3 to 4 days or 7 days later. That's a worrisome sign. A patient should be instructed for appropriate medication. Because of the swelling, patients are very apprehensive about food intake and the pain. We have to ascertain, we have to reassure the patient that food intake is as important as the medication, sometimes even more, because a starving body is a good area for infection. So patient should be advised, instead of some discomfort, always keep your mouth full, always keep your stomach full, and normal eating protocol should be followed. Balanced diet is mandatory. Appropriate water intake. If the patient dehydrates, then also you have bad post-surgical scene here. So advise the patient for good sleep of 8 hours, good oral rehydration, good amount of food intake. If the patient is not able to bite or chew, ask the patient to grind the food and then drink it or make it semi-solid and take it. A full stomach is mandatory. And ask the patient to come for suture removal. In this case, root canal treatment, periapical surgery, post-endodontic restoration has been completed. Now next thing is to manage the discoloration and the loss of crown structure, which is a different topic altogether for discussion some other day. Thank you all for your wonderful comments here, and all the questions I think have been answered. Do we have any question which is pending here? Yeah, this patient has not been found to have allergic reaction. Actually, we can't ask a patient about, many of them know betadine. If they don't know betadine, see, there is allergy, the event goes like there is first usage, which is called as a sensitizing dose. If the patient cannot be naturally allergic to anything, allergy comes as a chemical answer to the chemical structure to a specific antigen, specific chemical. So if that drug is being used for the first time, you cannot get allergic reaction. Suppose a patient is allergic to LA, allergic to antibiotics, first intake will always go uneventful because there is no immunity, there is no body memory to which a violent allergic reaction, immune reaction can be posed by the body. So I hope I answered the question here. No more questions? Thank you so much to everyone who has helped us, supported us, and registered for the conference and helped us to organize this whole event. Thank you very much. Tomorrow 10 o'clock is the next surgery. Most welcome. Thank you.